Endotracheal suctioning involves the removal of sections by means of passing a catheter into the endotracheal tube. Before suctioning, determine if your institution requires an order. If so, obtain one. If a standard protocol for endotracheal suctioning is in place for intubated clients, be sure to adhere to your institution's policy when implementing the procedure. Clients with an endotracheal tube require suctioning when there are visible secretions in the airway or if the client is coughing or breathing against the ventilator. Other indications for the need to suction can include a transient increase in peak airway pressure, a decrease in tidal volume, or even a decrease in oxygenation, as noted by decreased SaO2. The nurse would suspect airway obstruction due to the presence of secretions or a mucus plug if the breath sounds are diminished or chest rises less than expected. When suctioning is required for a client with an endotracheal tube on the ventilator, the general practice is to use an inline suction catheter. These are especially helpful for clients who require positive end expiratory pressure, usually referred to as PEEP. Opening the system would create a loss in positive pressure on the alveoli. Suctioning is a sterile procedure. Although the inline suction catheter is a closed system, hands should be cleansed prior to any client procedures. In this case, use of an alcohol-based rub is as satisfactory as using soap and water. Check the setting for the suction device used for this suctioning. It should be set at -80 to -120 millimeters mercury. Prior to suctioning any client, conduct a baseline assessment for comparison during and after the procedure. Review the client's previous arterial blood gases and oxygen saturation values when available. Evaluate the client's ability to cough and voluntarily deep breathe. This will help the secretions to clear from the lungs as well as increase the tidal volume during the suctioning process. Be sure to explain the procedure to the client prior to starting, informing him or her that suctioning often will cause people to cough or gag, or even feel as if they are short of breath during the procedure. Telling the client why suctioning is needed might help to increase cooperation or tolerance. Throughout the procedure, offer frequent reassurance in order to reduce anxiety and minimize oxygen demand. Position the client in semi-Fowler's position unless contraindicated. This will promote better air entry into the lungs as well as allow the client to cough more effectively. The client should receive a brief period of high concentration of oxygen. This is called pre-oxygenation. It can be accomplished with a manual resuscitation bag or with a setting on the ventilator. Using the ventilator setting, pre-oxygenate according to agency policy and patient needs. Modifications in this step are made for clients on PEEP. If using the manual resuscitation bag connected to an oxygen source, squeeze the bag every 5 seconds for 30 seconds to hyperinflate the alveoli and increase their oxygen stores temporarily. Put on personal protective equipment as appropriate. This might include gloves, gown, and goggles or glasses. To minimize hypoxia, the catheter size should be no more than 1/2 of the diameter of the tube. Quickly but gently insert the inline catheter into the artificial airway without application of suction. Withdraw the catheter 1 to 2 centimeters to avoid suctioning tissue and apply intermittent suction while removing the catheter. This aspiration should not exceed 10 seconds but should be slow enough to allow for mucus to be grabbed by suction tip. Before suctioning again, pre-oxygenate the client as before prior to another suction pass. To promote clearing of the secretions, ask the client to cough in between suctioning passes, if possible. If the mucus seems too thick to move through the suction tubing, it is not recommended that saline or any other liquid be instilled in the endotracheal tube. In fact, saline and sputum act much like water and oil. If secretions are thickened, then increase the overall hydration for the client and use of mucolytic prior to suctioning. Once the suctioning process has been completed, and during suctioning as well, monitor the client's heart rate and rhythm, auscultate the lungs again, and follow the oxygen saturation level. Note the quality of the secretions, color, thickness, odor, and amount, and document in the client's record. The inline suction catheter is often packaged as a self-contained unit. It should be replaced if it becomes clogged or per the facility's replacement policy, often after 24 to 48 hours. The suction tubing connected to the canister is often changed when the canister is changed. This is when the canister is full or the secretions are thick or discolored. After any client care procedures, the hands need to be cleansed. When you are finished and the client is settled, document the change in the client's breath sounds and the client's response to the suctioning procedure. In the event the client does not have an inline suction catheter, then follow these steps. Assemble the sterile suction catheter, sterile gloves, and sterile basin filled with sterile water on the bedside table. Pre-oxygenate the client as described earlier using the manual resuscitation bag or ventilator setting. Be sure the connection of the ventilator tubing to the endotracheal tube is loose enough to be released with one hand. Open and put on the sterile gloves. Grasping the paper wrapper and the suction catheter, connect the suction catheter to the suction tubing. Remove the paper wrapper from the suction tubing, maintaining its sterility. Disconnect the endotracheal tube from the ventilator. Quickly but gently insert suction catheter as far as possible into artificial airway without application of suction. Withdraw the catheter 1 to 2 centimeters to avoid suctioning tissue and apply intermittent suction while rotating and removing the catheter. This aspiration should not exceed 10 to 15 seconds, but should be slow enough to allow for mucus to be grabbed by the suction tip. If repeat suctioning is required, then repeat the pre-oxygenate steps as before. A second person will be required to do this manually so as not to break sterility. Rinse the catheter by dipping into sterile water between suction passes. When finished with the endotracheal suction, the rinsed catheter can then be used to suction the client's mouth before and after oral hygiene. Having an endotracheal tube can be uncomfortable. Oral hygiene is very important to the client's comfort. Wearing non-sterile gloves and using a soft or foam toothbrush and mild toothpaste is recommended. Use half-strength hydrogen peroxide and mouthwash mixed with water per your facility's protocol. Oral suctioning with an oral suction tip is used to remove dripped liquids from the oral cleaning procedure. As described earlier, monitor the client's response to the suctioning. Cleanse hands and document the response in the client's record. Suctioning is a necessary support procedure for clients who cannot clear their own airways. It is done with caution and comfort in mind. While it can appear to be very uncomfortable for the client, the results are better oxygenation and therefore increased client comfort.